Okay. Well, let me just start by saying I've known you for an awfully long time. Your talks are always fantastic, but this one is a chart topper.
Thank you.
Yeah, it's your ability to cover all these bases and all the gray space between clinicians and researchers and government entities and patients is just remarkable. So thank you so much.
Thank you, Phil.
So we have a boatload of questions and my colleagues and I are doing our best to prioritize them. I'm going to start with the following. There are three terms that are often discussed, at least in the ME/CFS community, only one of which you really hit on, and they're kind of related. And I'm wondering if you can talk a little bit about your theory and how it relates to the vagus nerve and homeostasis. So hypothalamus, vagus nerve, homeostasis, how do these things relate to one another with regards to this theory you presented?
Well, vagus nerve is the main signal that inflammation elsewhere in the body, outside the brain, uses to send signals to the brain. So the vagus nerve is, on one hand, the highway to the brain that alerts the brain that there is inflammation somewhere in the body. Mike Van Elseker has also proposed that the cells that wrap themselves around, some of the cells that wrap themselves around the vagus nerve could themselves become infected and inflamed and be a source of those signals that causes the brain's immune system to turn on and lead to the sickness symptoms. So I think the vagus nerve is absolutely a central part of the overall theory that I presented. Homeostasis, harder for me to address. The autonomic nervous system maintains a homeostasis. What does homeostasis mean? It means when the body tries to do one thing, there is another part of the body that keeps it from going too far and quiets it down. And these two systems keep themselves in balance, or supposed to keep themselves in balance. The autonomic nervous system, for example, one part of it, the sympathetic nervous system, can raise blood pressure, but the parasympathetic part can lower blood pressure. And what you need is a well-modulated crosstalk between the sympathetic and parasympathetic systems so that your pressure is going up when it needs to, but not too far. It's going down when it needs to, but not too far. And what happens in many people with ME/CFS and long COVID is that modulation, that homeostasis between the two arms of the autonomic nervous system becomes a little imbalanced. It's not as smooth. The blood pressure raising part may get too high before the part that's supposed to quiet it down kicks in to try to quiet it down, and vice versa. So that's the one kind of homeostasis that I can see as part of the pathology of ME/CFS. And the third term, Phil, remind me?
Oh, you got them all. Hypothalamus,
Yeah.
vagus nerve, and homeostasis. Yeah,
Okay.
You covered the hypothalamus. So the question that most people are interested in is there any evidence that rehabilitation of the autonomic nervous system, which I suppose would be the restoration of homeostasis to some degree, can be helpful or in fact curative for people with ME/CFS?
Well, curative I would be a little skeptical about, because that would imply that the dysregulation of the autonomic nervous system is the only thing leading to the symptoms of ME/CFS. And I don't believe that's likely to be the case. And I'm no expert on autonomic nervous system function. I also don't know of any way yet figured out of restoring the balance, the homeostasis between the two arms. But the good news is that the autonomic nervous system experts who are have been called into action by long COVID are also increasingly, at least I hear from anecdotes around the country, seeing patients with ME/CFS and offering them treatments based on the autonomic dysfunction that help, don't cure, but help with the symptoms.
Okay. How about moving to exacerbation of symptoms? Can you comment on post-exertional malaise and what's happening in the post-exertional malaise process that exacerbates symptoms? I apologize if you're hearing my dog bark.
No problem. I like dogs. Post-exertional malaise turns out not to be a temporary part of ME/CFS, but also a permanent part of both ME/CFS and, so far as we can call anything permanent, long COVID. For at least 2 years, people who got long COVID continue to have post-exertional malaise. Does pushing yourself too hard, physically or mentally, leading to post-exertional malaise, make it harder for you to recover from ME/CFS or from long COVID? I don't know of any evidence that that's the case, if that's the implication of the question. My advice to people always has been, as you can recall, that you should be very careful about how much physical exertion that you engage in. You should avoid, if you have either of these two illnesses, you should avoid any activity that requires a really vigorous physical activity in a short window of time, because you may pay a price for the next several days, possibly longer. On the other hand, I think there are many patients I've had who, if they're careful about it and engage in regular exercise programs that are slowly escalated or graded in increase, can feel better as a result of that. But some of them will have episodes of post-exertional malaise and stop the exercise for a month or two and then go back to it. There is a risk to trying regular exertion, but it also improves how some people feel if they don't push themselves too hard. What's too hard? No doctor can ever define that for you. The wisdom of your body will tell you, and it'll be like most of life's lessons. The way you learn those lessons is to experience them and find out what you should not do the next time.
Yeah, I appreciate that answer very much, because as you know, graded exercise is a trigger point for folks, because doctors who have no understanding of the illness sort of push patients. But in fact, I certainly agree, and I've seen hundreds of times where slow increases in exercise are tolerable and lead to some improvement.
I just hasten to agree with you there. I want it to be clear that I absolutely do not support the doctor expert who tells you the solution to your problem is just to exercise more. And there are an embarrassingly large number of people who think that they're experts, but in this instance, don't know what they're talking about, who have caused harm to patients. That said, I am also not saying, oh, don't exercise. That'll be worse for you. You just got to be very careful about it and willing to pay a periodic price when you don't think you pushed yourself too hard, but at least today you did. And so you've got to back off for a while and then try again. That to me is the most reasonable thing.
Thanks for the clarification. You mentioned doctors who think they're experts. Can you comment on, there are a few questions here about who do I see? Is there a medical specialty that's going to own ME/CFS? What is a CFS expert? Can you comment on, assuming we are able to educate physicians much faster now than we have in the past, is there a type of physician that one should be searching for? Is there a medical specialty that you foresee will eventually own this illness? And lastly, what is the role, in your view, of the PCP?
All very good questions without easy answers. On one hand, what I've said today is that this illness involves infection, involves the brain and autonomic nervous system, involves metabolism, involves the immune response, and there are experts in each of those areas. And for an illness that involves so many different kinds of abnormalities, you would almost hope that one specialty didn't own it, because if they did, they would probably have blinders on. They'd be very good at focusing on the part of your illness that they know a lot about, and they might ignore the parts of your illness that they don't know a lot about. My hope is that PCPs, who after all care for most patients in the country longitudinally, will become more knowledgeable about both of these illnesses. I agree with you, Phil, that the good news is that electronic technology has made it easier to get educated from the most knowledgeable people at a distance. Education can be done a lot more efficiently today than it could when I was starting out, for example. Dr. Bateman at the Bateman Horn Center in Salt Lake City is organizing a series of continuing medical education sessions for physicians, most of them primary care physicians, to teach them about these illnesses using streaming and podcasting and electronic technology that allows people to get educated at the moment that they have the time to be educated. The problem with traditional education is if the course is being given on Monday morning at 9 a.m. and that's it, and you just can't be there Monday morning at 9 a.m., you're out. Today, if a doctor wants to learn something at 7 o'clock at night, they can do it then. And if they have to stop halfway through to take care of a child who's having trouble falling asleep, they can come back to it after they're done with their kid. It's much more easy to get the education that you need. So I'm hoping we still have a huge problem with not enough doctors in this country who care for either ME/CFS or long COVID patients and have long experience with it. I hope long COVID will generate a whole group of new doctors that know how to deal with long COVID, and that the lessons they learn will apply to ME/CFS so they can help people with ME/CFS. But right now it's a bit of a mess because there are more people with both illnesses than there are doctors who have long experience with either illness.
Okay, yeah, that's a tough one to,
Yeah.
I'll leave it there. Let me move on to biomarkers and case definitions, and there's a whole bunch of questions about, is it that important to have a case definition of ME/CFS now? How does it relate to what the case definition is of long COVID? Is there some umbrella term? People have proposed PAPIS, post something or other, infectious umbrella term that needs some kind of case definition or definition. But how does all of that, the need for case definitions and the use of case definitions, play into the current surge of funding at NIH and the studies that are being done? Are things going to be immediately translatable?
Yeah, it's a very good question. And before the COVID pandemic, I would have said to you, I'm a big believer in case definitions. They're almost never right the first time around, and they almost always need to be amended over time as you learn more about a new illness. But they're really helpful in scientific research at making sure that the studies that are on a supposed disease are really apples versus apples comparisons. They're all talking about the same patients. With COVID, my advice, for what it was worth to the NIH, was rather than focusing on creating a case definition, what should be done, and I hope will be done, is being done with the COVID funding, the RECOVER study, is that what they all agree on doing is collecting exactly the same data, meaning the same symptoms, and asking about those symptoms in the same way. So if someone says, I have brain fog, for example, what exactly do they mean by that? Are they talking about a problem with memory, a problem with paying attention, a problem with confusion about the direction that they're supposed to be going in? I mean, brain fog can mean a lot of different things. What do they mean? And systematic collection of, if physical examination is done, what parts of the physical examination and how is it done? And if people are looking to see if the liver is enlarged, how exactly are they defining that the liver is enlarged? And then lastly, all of the tests that are being done, that those tests be done in a standardized way, meaning the same tests performed in the same way by different laboratories. And then what that gives you at the end of the day is this huge database. And then you can ask, well, we will identify some patients who seem to have gotten completely better from long COVID and others who have not. Now let's look at the database and see if we can predict who got better and who did not. Are there certain symptoms that make your prognosis worse? Are there certain laboratory tests that make your prognosis worse? Can we create case definitions by examining the data that we have systematically created after the fact, and not worry so much about off the top of our heads creating the case definition at the beginning of the pandemic? That was my advice. I think, I'm sure it was not just my advice, and I think that appears to be what they're doing.
Okay, moving on.
I can tell you from painful experience as someone who has participated in creating case definitions, looking back on it, I can see mistakes that those of us involved made in the elements of the case definition and in the name given to the illness as part of the case definition. And, you know, no one gets it right all the time, and that's the problem with premature case definitions.
Let's move on to treatments. Of course, there's a lot of concern, frustration that Ampligen is being retrialed for long COVID. There's a lot of angst about the history of that with ME/CFS. The question is, in general, can you comment about the likelihood that that Ampligen will in fact turn out to be either helpful or curative in long COVID? And if so, will that suggest that it be helpful or curative with ME/CFS? And the other two medicines that are in common use that I'd like you to comment on are Abilify and low-dose Naltrexone.
Right. As for Ampligen, it has been subjected to several randomized controlled trials, which are the way, in my belief and many people's belief, you can establish whether a drug really is effective. And those published trials have shown some benefits in the cardiopulmonary exercise test results, but haven't persuasively, at least to me, shown benefits in symptom improvement and long-term prognosis. First of all, they've been short-term trials, 12 weeks, 18 weeks, whatever, but this is not a 12-week illness. This is a long-term illness. And what all of us want to know is there any treatment that's going to fix this more or less permanently? And the Ampligen trials don't tell us that because they weren't conducted for long enough. So I am delighted to know that Ampligen is being tried in a randomized trial in long COVID, because since I've told you, I think the underlying pathophysiology, the underlying biological abnormalities of the illnesses are similar. It could very well be, there's a reasonable possibility that it would be helpful in long COVID, but I wouldn't prophesy whether it will or not. That's why you do the randomized controlled trial, to get an answer that you can scientifically respect, not a guess. So that's all I'd say about Ampligen. Maybe the one other thing to say about Ampligen that I'm sure will make some people unhappy is that there was evidence presented publicly at an FDA hearing that I was a part of, that some of the data that had been reported in the Ampligen trials of ME/CFS was incorrect, which made me step back and say, oh, well, I wonder if the data that's been published might also be incorrect. So Ampligen, it's a wait and see proposition for me. Low-dose Naltrexone. I have never used low-dose Naltrexone when I was in practice for 45 years. But everything I've heard from my colleagues who have used it, and everything I've read about it, its use in other illnesses as well, says to me it could very well help some people, and its potential, if used properly, to cause harm is quite small. So I've when people ask me which drug should major money be committed to study in large randomized trials, I think low-dose Naltrexone is one of those drugs. And the third thing you asked me about was, Abilify.
Okay.
There is Hector Bonilla's very small but encouraging report, and I hope that the manufacturers of Abilify will agree to fund a large study that's a randomized trial that will put that encouraging report to the test and find out if it really might be helpful.
Okay, we're moving on to the Recover Initiative, which you commented on, and uh, happily and surprisingly, there's a list of MECFS experts on the Recover site, and you're one of them. How important is that initiative? How much confidence do you have in it? Is there a particular way that folks who would like to participate or engage with it, either to keep current or to participate in trials, should go about doing that?
They, I haven't spent a lot of time on it, but they have a website and a regular email newsletter that do a pretty good job of keeping people abreast of how things are going with the study. I was involved in discussions about the Recover program early on, but I'm not currently involved in monitoring the progress of the study and as part of any oversight committee, partly by my own choice. I'm at an age where I can choose to spend my time on the absolute top priority things. And for me, the top priority are the studies of ME/CFS and long COVID that we're doing, and not the Recover study. It got off the ground slowly. I think it's sort of embarrassing that a scientifically sophisticated nation such as ours, a wealthy nation such as ours, should commit to doing a study like the Recover study in February of 2021, when the pandemic and the cases of long COVID that were emerging from it were clear 9 months before, and then committing in February 2021 didn't really get the study going until late 2021, and it's behind schedule in terms of enrolling patients. Now, that's too bad. I don't want to minimize how hard it is to organize a study involving this many different centers and doctors and patients. I feel for the people charged with doing it. But having said that, we're a nation that knew another pandemic was coming. And we should have been much better prepared, not just to study long COVID, but to be prepared to develop rapid tests and vaccines and to be able to distribute those vaccines to everyone as fast as possible. We have not been very well organized in responding to this latest pandemic. And we're not doing the things that we need to do to be better organized for the next pandemic. That's my larger concern than the Recover study per se.
I'll hold it there. Thank you kindly. We're sadly out of time. There are a lot of great questions that I wasn't able to get to, but we've all been at this for a very long time, and I'm sure some of them eventually will be answered. So I'm going to turn it back to Karen with my personal thanks, and take it away, Karen.